So for our audience, quickly, tell us a little bit about who Sharon Malone is and what she cares most about.
Yes, I am a physician, but more than that, I'm a daughter, I'm a sister, I'm a friend. I grew up in the southern Alabama, Mobile, Alabama, not rural, but it seemed like it. And I know what it means to be on the other side of that medical desk. I know what it means to have lack of access. I know what it means to be ignored and to not really have your needs addressed. That was really how I grew up. So as I became a physician, I wanted to make sure that I brought that perspective with me always.
That's great. And I often realize that sometimes our pain informs our purpose. Can you tell us what happened in your world that drove you to your career?
Yes, I had the unfortunate circumstance of being the last of 8 children, and I say unfortunate because my mother died when I was 12 years old. And so I had the least of my mother, but I also got to see what it meant to not have the education, to not have the access to care. And when I was growing up, it was still very much the segregated South in Mobile. So I saw how my mother was treated. I saw all the things, this very competent, intelligent woman who didn't know enough about what was happening with her to be able to access care in a timely fashion. And my mother died of colon cancer at only 57. And I know now that colon cancer is something that, if detected early, could be entirely curable.
Thank you for sharing that story, and I'm really sorry for your loss. You were very young when that happened. So talk to us today about what are some of the trends that you see in the medical industry.
There are a few trends that are positive, and there are some that are relatively alarming. And, when I wrote a book, and when I wrote the book, I really wrote it from the perspective of being an advocate for patients, because I wanted them to understand, in this changing medical world, what is it that you need to know to bring to this interaction to make sure that you get everything that you need to get out of this, because it's changed. I started practicing medicine, 35 years ago, and the world that I was brought up in medicine is not the world that we're in today.
That's really important. Let me give a little backstory just for context. When I was managing money, I was tapped to be the industry strategy chair, so you would look out 5 years instead of what analysts consider like quarter to quarter. What's going to happen over time? And you have to pick up her book. It's incredible, because she identifies some things that have happened over time to give a sense of what is likely to happen going forward. So talk to us about this crisis that you see right now in the medical industry.
Well, when I started 35 years ago, I was there when we had that first big inflection point about how medicine was practiced. We went from the doctor being in charge to now their HMOs and insurance companies dictate how care is given and what you can and cannot do. So that was the first big seismic change. And complain mightily though we did, we have all adjusted to that change in how medical care is delivered. But now we are at another very serious inflection point, which is changing the care that you will get, and it's also changing how doctors will work. Currently, about 70% of medical practices are no longer physician-owned. They are either owned by private equity groups, or large corporate entities will come in and buy them, or hospital groups. So what that means for you is that your doctor is now an employee. And that changes the nature of the doctor-patient relationship. It changes the loyalty that doctors have to the practice, because they are not owners, they are employees, and they will act accordingly. That's just human nature. But it also means that the nature of the relationship, where a doctor may be in place for 30 years, like I was, may not be the case. You're an employee, you may leave, you may go someplace else or get a better job. But also, it's changed just the nature of the individual appointment. I could talk to my patients as long as I wanted to, and sometimes, I would run over because you needed more time. But now, as an employee, it's dictated to you how many patients you will see in the course of a day. So what that means is that you will get, on average, 5 to 7 minutes of doctor FaceTime. That's it. And it's not because your doctors want to do a bad job. That's not it. I think that they would love to spend more time, but they're on the clock like everybody else. And that means something very different for you. How are you going to show up and prepare yourself when you know that you've got a limited amount of time of that doctor FaceTime? Well, and that's the kind of thing that I talk about. I think that, you can say it's bad, it's good. I think that most people would say it's not great. But that is the world that we are living in, because we are also faced with an impending doctor shortage, which is getting larger and larger as we need more health care in this country.
Thank you so much for sharing that. The other point that we discussed that I think is really important is that doctors are making different choices. Let's talk about that.
The way it typically would work, you can go to medical school, you train someplace that you want to live, and 9 times out of 10, you like that place, you meet the people, and that's where you stay in practice. But what is happening now in the post-Dobbs era is that we are finding, particularly when it comes to women's health care, we are seeing fewer people that want to choose to stay in OB and to do obstetrics and gynecology. And 63% of medical students and residents would say, as an important factor in choosing where they will train, they do not want to go to states where they have restrictive abortion laws.
That makes sense.
And it makes sense. But what does that mean? Because it's not just about abortion. It is about the fact that women, for the first probably 2/3 of their lives, will get their primary care from an OBGYN.
That's right.
So it's not just about abortions, it's about who is doing breast exams, who's doing cancer screening, who is doing preventative care counseling for you. And if those doctors are not present, then that's a problem for all of us. It's not just abortion, and that's the point I really want to make. It is not a political decision, because everybody will be affected, regardless of your political affiliation. If you're in a state that is underserved, all of us will suffer. And I think that even currently, what people don't understand is that the people who are always going to be affected most are people in rural America and people who live in large urban areas and disadvantaged areas. 50% of the counties in this country currently do not have a practicing OBGYN. How is that going to affect the maternal health care crisis when you don't even have someone that you can see?
Isn't that amazing? I saw these stats that you shared and I was just blown away. By the way, I was born in Tuskegee.
You
So
were.
we're both Alabama girls.
Love it.
Alabama. So those stats and those facts are pretty depressing.
Yeah.
Yet you have hope. What are you seeing that gives you some confidence? And what is it that the audience can do?
You know what? I do have hope. And here is also something that gives me great joy, is that there is not a lack of interest in medicine. We need young people. We need them more than ever to be interested, and most of them really come to this from a perspective of trying to be helpful. But what can we do now that we're aware of the program, of this problem? We need to understand that there are things that we can do to advocate for ourselves. I've spent a career teaching women how to advocate for themselves in a doctor's office. That's the little a advocacy. But the big A advocacy is the things that we can do collectively. And I've done a lot of that on the menopause front for women in midlife, because there is a lot of the things that are happening can't have legislative and policy fixes.
Yes.
So, this is a very important time for you to say, well, you can't say, well, the federal government isn't going to do this or do that. That's a problem. But on a state level, on a local level, so much of this is going to be done and is being done now, because we've got now 1 in 4 states have already introduced bills for menopause care and for women in midlife. So if you think that your voice is not being heard, don't believe it. Now that you know, I want everybody here to go out and talk to their state and local legislators to say, women's health matters. It is not just a 1 or 2, button issue for us. It's all of us. And the advocacy that we can use to make our points and our voices heard, and I'll tell you another little tidbit before we go. One of the things that I found out as I was doing research is that, for women, we are 51% of the population. NIH, which is the largest funder of medical research in this country, we get less than 11% of the dollars that go to women's health. 11%, we're 51% of the population. I would say we're 60% of the voting population. I think we should use that voice to say we demand more, and now that we know more, we know what to do.
Exactly. And Sharon, when you look at the NIH and it would invest in solutions, you presented some great research that showed that it's not only about the improvements in technology, but the importance of access. Can you speak a little bit about that?
Yes. When we frame the argument that we've got an access problem that is going to loom larger as we age, and let me just say this is a problem because I'm at the age now, in the next 10 years, I'm probably going to need some medical care. So I need somebody to be there for me. This is what we have to do. We have to understand that the old model of care delivery doesn't work in the 21st century. We have technology. We are going to have to figure out how to utilize AI, how we are going to train and use the professionals, nurse practitioners, physician assistants, but we're also going to have to use digital health. Yes. That is the only way that we're going to be able to leverage the expertise of one doctor or a few doctors over many hundreds of patients in the course of a day, not just the 10 or 15 that you can see. And that's going to be important. And I think that the next generation is really comfortable living in a digital world. And we have to understand that that's just one more tool that we need to be able to have every person in this country have access to quality medical care.
That is right. And one of the points that I wanted us to know is that, can you tell them what happens with maternal health? Because sometimes people say, if you have the money and you can come up with additional technology, you're going to get better outcomes. But what have you found in your research?
Well, this is across the board, not just for maternal health. When it comes to the healthcare disparities, there are certain things, whether we're talking about cancer care, whether we're talking about heart care, and certainly maternal health, which is the most talked about of these disparities, it is pervasive. It is through everything, and your socioeconomic status does not really protect you. Your educational status does not protect you. We have to deal with the real implicit bias that exists in medicine. And there is a component of racism that we have to say that, let me just say, and it's not just about seeing a black doctor. We were all trained up in the same system. So the things that are problematic or things that we believe are things that we all have. So it requires some retraining and retooling of our workforce to be able to avoid those things that get in the way of equitable care.
That's right. And and wrapping it up, I like that chart that shows that in the 1930s, more women died when delivering birth many years ago. And they improved that significantly. And with improvement in technology, there's not always improvement in the gaps of care and the outcomes. And I found that really surprising.
Exactly. And that I use that chart to illustrate a point. And that the better we are at treating any particular condition, be it childbirth, be it cancer, when things are bad, they're bad for everybody because we don't know how to fix it. But when things get better, that's when the disparity widens. So the treatment, you're like, oh, we got all these great things, but that's why the maternal mortality disparity issue in 2025 is greater than it was in 1925, because now we've got more care and more technology and more, procedures. But if you can't get it, you may as well be living in 1925.
Exactly, and that's the point I wanted to bring out. Thank you, because it's by voting and with the technology, it can get better, but the two seem to need to go together.
Exactly. Okay. And I think that that's also something that I really want people to understand, is that disparity in healthcare outcomes is pervasive. If it were only maternal mortality, that might be an easier problem to fix. But the through line goes through all of healthcare, particularly for Black people in this country.
Thank you very much.